Yes, sir. On HFpEF, any information on Entresto and HFpEF?
Oh, yeah. When I talked about LVH and diastolic dysfunction, that was the phase 2 Entresto trial, the Paramount. Paragon is the ongoing phase 3 trial. Expected to be able to, we're going to finalize a follow-up in June 2019, and we're hoping to be on track to do late-breaking trials at the American Heart Association 2019. I don't know. It was an encouraging phase 2 pilot, but there's been a lot that's fallen by the waysides. So I'm hopeful, but we'll see.
Dr. Friedman?
Dr. McCully, thanks for a great talk. I wondered if you could tell us a little bit more about how mitochondrion gets endocytosed by a cardiomyocyte. Is there a specific receptor-ligand interaction? Is it fluid-based endocytosis? Do you have any clues?
No, I don't. It's just general endocytosis. We know they go in. My colleague is pounding out the small phase on there. Frankly, it wasn't a big thing on my radar. Once they get in, it was by endocytosis, and I figured that's fine. I know people are worrying about penocytosis and everything else. They just go in, and they go in rapidly.
Sir, in the back, and then.
Yeah. So, Dalane, is there a biomarker for HFpEF, like the equivalent of a BNP for left ventricular dysfunction?
Well, until recently, it was claimed that it was BNP, and trials that are being planned right now are still using BNP as a mandatory inclusion criteria. But I think that it's gravely imperfect. I wish there was, because it would help things tremendously. Defining this disorder and how to characterize it and what the criteria would be. The European Society of Cardiology has this complicated algorithm to do all this stuff and decide if you have HFpEF. The ACC says signs and symptoms of heart failure, eye bedside exam, normal ejection, preserved ejection fraction, and nothing else to account for their symptoms. You're done. It meets the syndrome. So it would be nice. I'm skeptical that we're likely to have a single marker anytime soon because of the work of Sanjeev Shah that's helped informed us that there are probably 5 different, at least, phenotypes of HFpEF. And before that discourages you and say, oh my gosh, I wish it were simple like HFrEF. Remember, HFrEF is tremendously heterogeneous, dilated cardiomyopathies without coronary disease, pure post-infarct, postpartum. This is not new under the sun. It shouldn't have surprised us that HFpEF was a heterogeneous syndrome. So in the same way that I'm not sure there is a single marker for HFrEF other than reduced ejection fraction, which is sort of artificial. But if you can find one, you will make a huge advance.
Last question.
This is a question for Dr. McCully and Dr. Emani about the sort of the very fascinating sort of longevity that the transplantation has. What are your thoughts about, even in the absence of overt evidence of ischemia or concern about ischemia reperfusion injury, just given how robust it is in the setting of anticipating a low EF or concern for arrhythmias in the sort of surgical setting about just sort of prophylactically getting to a point where one could prophylactically get this as a treatment?
We're doing that now. We do it. 2 of my fellows have just finished the studies. We can give it prophylactically prior to ischemia, and it still provides protection. We can give it 2 hours after ischemia, and it provides the protection. The mechanisms are a little involved. They add some more, and I'd like to just leave them. I don't want to be sort of childish on this, but we have to leave them for a little while. There are interesting mechanisms involved with it. But we see this as, with the cardio patch that was coming out here, we don't salvage, we don't rescue, we only rescue tissue. We don't regenerate it. But if you can keep that peri-infarct area small enough, we can see this as a bridge to allowing the cardio patch to go in later on within that region perhaps more efficiently, so that perhaps you don't need one 7 by 7 centimeters. You could use a smaller one, get it in, get it vascularized a lot quicker. I think surgically, Dr. Emani could talk to that. I think some of the decision making is interesting there.
Well, I want to thank you again for a wonderful set of speakers.